position, you know what I mean, is very important because proper pelvic tilt. Oh, hey there! It's Dr. Evan Osar. Welcome to this edition of Integrative Movement Insider. Happy Tuesday. Hope your week started out well. Today we are continuing our discussion about the pelvis and pelvic floor. Hello, my good friend, my best friend, Pete Rislow from NJ. Today we're continuing our discussion about the pelvic floor and the position of the pelvis, and we're covering some of the research that has come out about the pelvic floor, because people often in our industry like to talk about posture and how it doesn't matter. There's no research to support the importance of posture, and Dr. Osar, why do you waste your time talking about that kind of nonsense? Well, there's actually a study that came out in 2008. There's lots of studies, good amount of studies that have come out recently, in recent years, about the position of the pelvis and the pelvic floor. And why are we discussing this? Because this is May. This is Mother's Day, I believe, is this Sunday. So happy Mother's Day, early happy Mother's Day to all the mothers out there. So we know that a lot of women experience stress urinary incontinence. And that's incontinence when you stress out your body. So when you cough, sneeze, laugh, and or exercise, exert pressure down into the abdominal and pelvic areas, then there's some leakage. And we know a lot of women experience this issue. And it's not just women. Women after pregnancy, or older women. So at least 1 in 3, probably 1 in 4, maybe even more than that. Older women after pregnancies and birth and as they get older, absolutely changes in the pelvic floor and menstrual cycles and so forth, menopause, they will have urinary incontinence. But if you actually look at the research, even 7% of young girls are having stress urinary incontinence. And one of the biggest populations that actually experience stress urinary incontinence is athletic women. So a lot of you watching this and a lot of the clients that you're working with as fitness professionals, as chiropractors, as physical therapists, are dealing with this issue of stress urinary incontinence. So, and they say that it's really underreported, underdiscussed, underdiagnosed, and therefore undertreated. So why am I discussing this? Obviously, I'm not I'm not a pelvic floor therapist. However, as I talked about in last week's episode, it's very important that you stay within your scope of practice and find a great pelvic floor therapist to work with. We have one in our region that we work with, and we've worked with her for many years. I trust her. I've gone to her myself just to understand the pelvic floor, both in my own body, but then as a function of wanting to help the people that I work with. So it's important that I understand what pelvic floor therapy is all about, that I trust the person that I'm referring my patients to. So find that person in your area. It's easier now because there's more pelvic floor therapists that specialize, or I should say therapists that specialize in the pelvic floor and treating issues with your female clients. So that's the first piece of advice. Now the second piece of advice that comes back to that research is the position of the pelvis. So the study in 2008 by Sepsford and others, actually Paul Hodges was part of that study as well, looked at the position of sitting and the activation of the pelvic floor muscles. And what they found was, it was a small study, I believe there's 17 people in the study. They looked at a group of continent women and incontinent women and just the difference in the pelvic floor activation. And what they found was women that sat in a slumped position, so basically posterior pelvic tilt with the loss of the lumbar lordosis, they had less activation, they had less activation of the pelvic floor. However, the more they moved from that posterior pelvic tilted position and lumbar spine flex position and more into a more neutral and lordotic curvature of their lumbar spine, the more their pelvic floor became, or the more active their pelvic floor became. So it did show that the change in pelvis position did change the activation of the pelvic floor muscles, the muscles that sit inside the pelvic bowl and support the abdominal organs and work with the diaphragm to create stability and stabilization, control that pressure inside the cylinder. Now, what they also found was women that were incontinent, they actually had less ability to find and get to that more neutral position or that more lordotic position of the lumbar spine. So we have seen this in our clinic as well. People that tend to have more pelvic floor pain or discomfort or urinary incontinence and or low back pain, they tend to have different postures and have more trouble getting into more neutral pelvic position and more lordosis of their lumbar spine. Now, please don't take this to mean like we should force our clients into anterior pelvic rotation and or lumbar lordosis. It just means that this position can be important for many of our clients or some of our clients that are experiencing pelvic floor issues. So, first thing, let's finding a more neutral position for your client's pelvis. So one of the easiest ways to do that, and again, neutral pelvis is relative to your client. It's not a position that's the same for every single person. So if you think about the pelvis as a bowl, if you're carrying if you're spilling no water out of the bowl, you're in slightly you're in slight posterior pelvic tilt. So if your pelvis is a bowl and you're not spilling any water out of the bowl, you're in slight posterior pelvic tilt. If you're spilling a little bit of water out the front side of the pelvis or the pelvic bowl, then you're in slight anterior pelvic tilt. If you're just like pouring it out, you're way far anterior. And again, if you're pouring it out the backside, you're way posterior. Now, very few clients are way anterior. Why? Put yourself in anterior pelvic tilt. Doesn't feel good, doesn't look good. Doesn't look good unless you're a selfie model, because they're always like this in their videos, right? But it doesn't feel good. It feels awful on my lumbar facet joints because I'm basically jamming my facet joints together. So most people don't walk around in this posture. Now, some people do, but very few people will choose that posture and definitely will not sit in that posture. Now, what about those clients that are way posterior pelvic tilt like that? Well, those are mostly your clients, your older clients, not always your older clients, but more on the older side of the population because they tend to have spinal stenosis. So they'll move their pelvis into that posterior pelvic tilted position. But again, what the study has found and what they suggest, and there's other studies that support this, that your organs should sit and be supported pretty much on your pubic symphysis, relatively speaking, especially your bladder, the bladder being one of the heavier organs, especially when it's full. Well, the more you go posterior, well, then now the bladder starts sitting and moving back into the pelvic bowl. So now the more the organs are feeding down into the opening there, the pelvic outlet there. So now there's more tension on the pelvic floor for that support. Now again, this is not to say force your clients into anterior pelvic rotation, force them into a lordotic position. It just means that if we can move them even from a position of excessive posterior pelvic tilt to a little bit more closer to a more optimal position, we can make a big change and maybe take some of the pressure off the pelvic floor and also get those pelvic floor muscles working well. So again, put your hands on your pelvis. Let's go into pretty far posterior pelvic tilt and then go pretty far into anterior pelvic tilt. Now you can do this lying down as well. So we'll often teach our clients how to do this lying down, and you've done this with your clients as well. And then just kind of find a happy medium between those two places, okay? So again, lying down or standing up, same idea. Now the second piece of that is once you've got your client into that more neutral position, is getting your clients to get their breath down this direction. So down towards the pelvis and down into the pelvic floor, because what should happen is when you're breathing, the diaphragm drops down to push the organs down. Well, the pelvic floor is down here and it should be accepting those organs. I should say it's essentially contracting as the organs are pushing down, but then it has to lift back up. So it's moving with the diaphragm as you're breathing so that it's counteracting the pressure put down on it by the diaphragm, and it's also helping to maintain that cylinder alignment. I should say cylinder, the pressure, which then also aligns and keeps the alignment. Okay? So we want to make sure that we're breathing down. We talked about this last week. Just a quick review. Put your fingers, find your ASIs, these bones that stick out here. Put your fingers in there. Your breath should go all the way down to the lower abdomen. That's the best sign that you and I have without doing internal pelvic exams, without doing ultrasounds. This is the best way that we can determine that at least the breath is getting down to activate that pelvic floor. So put your fingers inside your ASIs, breathe in, and you should feel slight distension. And when I say distension, it's just expansion. That's a better word. Distension, we'll talk about that in a moment here. Expansion of the lower abdominal wall. So you should feel the lower abdomen expanding out as you breathe in. And as you breathe out, you should feel the abdomen coming back in. Now, under quiet respiration, just respiration in quiet standing or sitting, you should not feel a lot of excessive tone. Because again, it should be relatively the diaphragm pushing down, the intercostal muscles expanding the rib cage. It should be a stretching of the abdominal wall and the fascia, and then it's just more of a relaxation, like a rubber band snapping back together, or I should say slowly coming back together as the elastic recoil of the connective tissue that brings things back together during quiet respiration. So we don't want to see a lot of abdominal wall activation, because another part of these studies, this study by Sapser and others, and also other studies that we've looked at, is usually with women that have stress urinary incontinence, men as well, they tend to have overactivation of their abdominal wall compared to their pelvic floor, meaning they start to grab and or contract their abdominal wall more than they activate their pelvic floor, and they're using too much effort even in quiet respiration. So we want to teach our clients how to breathe and even how to use their pelvic floor. Breathing is the best way to start that process without being a pelvic floor therapist that can do an internal exam and or give specific cues to the pelvic floor. So aligning is the first part, breathing is the second point. Now the third point is control, and now let's talk about the exercises. Now, especially during abdominal exercises, because a lot of our women after pregnancy, surgery, as they get older, I mean, who doesn't want to tone up their abs? I had an 86-year-old gentleman I'm working with. He's like, "Hey, Evan, what exercise can I do to tone up my abdominal wall?" I'm like, "Dude, you're 86, but he still wants to tone up his abdominal wall." So people, it doesn't matter what age, men, women, everybody wants a more toned abdominal wall. But that forces, I should say not forces, but it brings us to, like, a lot of people are then doing crazy leg exercises like leg lifts and flutter kicks and, crunches and sit-ups and things like that. So we want to think about our abdominal exercises. What's the function of the abdominal wall? It's really not to flex it this direction. And again, the more we flex this direction, we're actually, especially again, as it relates to these women with stress urinary incontinence or men, we're putting more pressure down into the abdominal wall. So I'm going to jump on my back here. What we're going to see oftentimes with our clients, or you see this in the gym all the time, is when people, they're doing some kind of abdominal exercise, instead of seeing a nice cylinder alignment, you watch them, and as soon as they lift their legs up, you see this extension, you see this abdominal distension, you'll see them going into cervical extension, okay? So you want to make sure that if you're doing supine abdominal exercises, that your client is able to maintain this alignment, keep their breath going down, and then as they bring their legs up, there's no change in alignment. Obviously, they're activating the core more, but there's no change in their alignment. So if they're doing a heel drop, they're able to actually maintain this alignment. They're maintaining breathing, even though the breathing isn't as full. They should actually be able to have a conversation with you, because if you see them, or if they're holding their breath, they're not having a conversation. If their face is turning red, if they're shaking like this, they're not training their core in an optimal manner. They're likely doing a Valsalvas, which is bracing and putting too much pressure down into the pelvic floor, into the lower abdomen, which again is putting more stress on that pelvic floor, so not using it in an optimal manner. Now, as you get your clients upright, and now you're starting to do more weight-bearing exercises, so squatting, lunging, bending, we want to, again, obviously load our clients up. We want them to be more, we want them to be stronger, develop muscle mass, bone density, all the things we'll talk about in this new series of Two Anatomy Geeks. We want to make sure also that their pelvic floor is working well here as well. Okay, so we talked about this last week. So you're going to breathe in, just to get the pelvic floor working in an upright position. Have your client breathe in as they lower down, breathe out, and just do that gentle pelvic floor sort of lift as they breathe out. So breathe in, breathe out. So you start out just teaching your client how to coordinate breathing, pelvic floor motion, as well as overall body motion. Now, obviously, you need to train your clients also for endurance and speed, right? You need the pelvic floor to contract before the rest of the muscles so that you have continence. So once you've taught your clients better breathing and they've worked with a pelvic floor therapist to learn the right cues for them, now you cue them up so that when they're stepping, for example, doing a lateral lunge or a forward lunge, they're able to pre-activate that pelvic floor prior to contact, so that way they have activation of their pelvic floor. And there's actually a study that came out that said the lumbricals of the foot and the pelvic floor contract at the same time, which makes sense because they're postural muscles. The muscles in between the feet also tie into the pelvic floor. So the position and control of the foot is also important to pelvic floor health as well. So there's a few things to think about, and lots of things that we'll be covering this week. Starting this Saturday is part 1 of Two Anatomy Geeks, where we'll cover the pelvic floor and the anatomy of the pelvic pelvic floor, the hip rotators, because the other way that you can impact the pelvic floor is through the hip rotators. The hip rotators actually have fascial connections into the pelvic floor. The adductors also fascially blend into the pelvic floor and have overflow into the pelvic floor. So we'll discuss those muscles and help you create a strategy for your female clients. If you're not a pelvic floor therapist, knowing this information will help a lot of your clients. It'll help you communicate better with your client's pelvic floor therapist and their healthcare team, and help make you a valuable part of your client's medical team as well. So we'd love to have you and Two Anatomy Geeks. It's a 3-part series starting this Saturday where Jill, my fellow anatomy geek, and I, we will be covering in week 1 pelvic floor and the hip rotators and how some of the research around how to use the pelvic floor appropriately and integrate it into exercise. I gave you a couple samples of that here today. Week 2, we've got a special geek coming on to talk about surgery and the impact of the menstrual cycle and training women around their menstrual cycle, things you want to think about, because when a woman's coming close to her menstrual cycle, the body's preparing to have a baby, right? So there's going to be some ligament laxity and some issues around that you want to be aware of as well. Women that have had C-sections, hysterectomies, and other abdominal GI surgeries or pelvic surgeries, they're going to have significant changes to their motor control, how the brain connects with the muscles, as well as potentially having scar tissue. So our expert will talk about that as well, and we'll talk about exercise considerations around that. And then in week 3, the 3rd part of the series, we'll discuss all things bone density. Obviously, we know many of our female clients have bone density issues. So we'll talk about some of the information around bone density. We'll talk about some of the exercises and ways to increase bone density, because exercise is the #1 way, obviously I should say, part of the #1 way to increase bone density, nutrition being a big key of that, or important key of that as well. So I actually will be doing an interview with my personal nutritionist, and the nutritionist we refer our patients to, Sherry Belcher, will be doing an interview with me, all talking about bone density, natural ways to improve bone density. And again, this is not medical advice. We're not saying, hey, go take these supplements or eat this certain nutrition. It's just awareness to give you education and give you some things to talk about and communicate to your clients so they can have those discussions with their medical professionals. Because we want you guys to really be the go-to expert for your female clients, because I know you're training clients, I know you're training clients that come in and ask you these questions, so we want you guys to be that resource and to be able to answer them confidently and direct them in the right direction. So we've got a lot for you coming up in this 3-part series. And again, it's May, it's Mother's Day, so we look forward to having you guys as part of our community. It's really a wonderful community of like-minded individuals. I see a few of you guys on here, so thanks so much for being part of our integrative movement system community and being part of our Two Anatomy Geeks community as well. Like I said, it's a group of open-minded health and fitness professionals that are just looking to support each other, to learn information, and to impact lives and empower our clients. Because again, that's our #1 goal: educate, enroll, educate, and empower. So we look forward to seeing you. The link is next to this video wherever you're watching it. And we look forward to seeing you this Saturday, and all sessions are recorded, so if you can't be on live, you can catch the recording, and we'll apply for CCs once this series is completed. So, without anything else right now, this is Dr. Osar with Integrative Movement Insider. Hey, and for all you mothers out there, I've been blessed to be around so many wonderful women. Obviously I was born to a woman. However, I was adopted by a woman, and my sister became my godmother, and she had no children of her own, and I'm very blessed to have her as a godmother, and basically the mother that the universe sent me out to find. I can look back in hindsight and said she was the mother I was supposed to have, and so I'm thankful to all the women in my life and the women around the world that really do so much for us and make this world a better place. So happy Mother's Day to you if you're a mom, and happy Mother's Day to your mothers as well from all of us here at Integrative Movement Institute. Thanks so much. Have a great day. We'll see you next time, and we'll see you at Two Anatomy Geeks this Saturday, 9 a.m. Pete, love you, brother. Be good. Bye-bye.